session here for Q&A, kind of whatever we want to cover today. I know Rachel has a little bit of a presentation for us to review some of the stuff that they covered at our previous coaching call with the Moms Plus team. Otherwise, feel free anytime during the discussion to like chat in questions. I mean, we'll pause frequently. This is really kind of your opportunity to get your face and your questions in front of the experts. Pretty informal here today, but I'll just hand it over to Rachel. We're all here if you guys need us.
Cool, sounds good. Gonna go ahead and start. And I may have a couple others joining us. Dr. Stater is coming on from another call. And then Dr. Klee had a competing call, but she said she'd call in for a little bit. My name's Rachel Duncan. I am program director for our Moms Plus. So really all focused on basically helping our birthing hospitals set up better treatment infrastructure, both in the hospital as well as when our perinatal patients leave the hospital, whether that's from a birthing admission or something pre or post baby, and really trying to get them plugged into treatment. And so we had a call last month where we really talked a little bit about some of the medication for opioid use disorder, and weren't able to make it through all the cases because they're often quite involved and we all have a lot of questions, which I think is great. So definitely feel free to pop questions in the chat or come off mute as we go through this. But I always find that it's best, I learn best through case-based learning. And so I hope everyone's okay with going through some cases today and utilizing some polling questions for some audience participation. But again, feel free to come off mute and just ask questions as well as we go through it. And so just as a refresher here, MOUD stands for medication for opioid use disorder. I think previously we thought more about the term MAT, medication assisted therapy, and you'll still see that, especially in the literature, just because historically that's what was used. And so we're just starting to see studies published using the new terminology. And the real reason for this is that I think previously, and historically, we had thought that medication was one piece of therapy for patients, but not the main one. And what we found through studies is that medication is the gold standard for therapy when it comes to opioid use disorder. And so due to things like tolerance, due to things like when folks return to use and their risk of then overdosing being so high, and then just how our chemistry and our neurobiology in our brain changes with opioids so significantly, we've really started to recognize that medication is actually the center of therapy. And only when folks can get on stable medication regimens, at least from the onset, can they then participate in other augmenting therapies. In fact, we've looked at studies that have compared both just, hey, put them on medication and see how they do. And then, okay, put them on medication and provide behavioral and addiction counseling. And there actually wasn't a significant difference. And I don't want that takeaway to be that those other services are not important. I want the takeaway to be that we have to start with the medication. Only when we can fix that can folks start to regain some of their executive functioning, especially for those in the most severe of use disorders. And so that's really the change from medication assisted to medication for OUD. And so just some nuances there. So let's start out with our first scenario. This is Quinn. They are 38 weeks pregnant and they present to L&D in active labor with their first baby. They have no prior prenatal care and actively use very high doses of fentanyl, which they purchase on the street. They abruptly stopped using fentanyl 9 hours ago when mild contractions began to try to hide use. They are terrified of being reported to CPS, knowing none of this. So this is Quinn's background, but you don't actually know any of this. Quinn just presents to you in labor. You begin universal screening procedures. And after doing a few site visits, we've done 4 so far for our Moms Plus program. Very pleased that those that have been participating in Colorado AIM-SUD are doing an excellent job with universal screening. And so kudos to those hospitals. I'm really, really proud because that truly is the first step. And so we're gonna go ahead and polling question here. How do you address Quinn? A, as a female, she is here delivering a baby after all. B, by the pronouns Quinn asks you to use. C, I'm not sure. All right, let me go back. There we go. And we are going to pop that question in the chat. Give you all a couple.
Just open the poll. Rachel, just let me know when you think I should close it, and I can, if y'all can see the results.
Yeah. So this is just talking about how do we address Quinn. And so give you guys a chance to respond, as we know that the how we start the interaction can often set the tone for the rest of that visit. So Sydney, you want to go ahead and pop up the answers there, what folks thought?
Yep.
It looked like the majority said by the pronouns Quinn asked you to use. And that is correct, right? I think that most of us are well aware of this at this point, that gender identity is very important and that we should really be affirming that in our patients. And so we need to make sure that we're using the pronouns that Quinn asks us to use. Perfect. So as we talk about screening and universal screening, I think that a key portion here is if this is not something that your staff is comfortable doing or has not historically been a part of every encounter with their patients, oftentimes scripting can be a helpful tool to utilize as well as practicing, right? And so we really want to normalize questions as part of our comprehensive medical care for the pregnant person and the infant. And so, oh wow, that's intense how many times I have to click. But I think one example of what you could utilize, and this can either be scripting that the screener says, or also a lot of folks are starting to utilize kind of patient information cards, as sometimes these things are done maybe, especially in clinic visits, maybe prior to on an iPad sitting there. But really normalizing it and talking about the why behind it, as well as attaching some expectations with it and telling folks what to expect. And so this is an example of a scripting tool that you could use, and just talking about, we're working really hard to improve and increase care for people in our community with any type of substance use, right? We know substance use is common, whether that patient is pregnant or not. In the perinatal period, we know that substance use is anywhere from about 6% for illicit substances, all the way up to a quarter of patients maybe using things like nicotine or alcohol. And so we need to start acknowledging that. And so one practice we started is asking everyone who gets their prenatal or OB care with us about substance use. We ask everyone the same questions. Is now a good time to go through this questionnaire? And so really inviting their participation and allowing them to decide with you. And so other things, Quinn asks why the screening is being done, right? A very common thing to ask. And so setting the why, I think, is also really important here. And so this is some of the types of examples that you could use and really tell the why behind it. Everything we should do should have a purpose and have the possibility of changing our care for that patient, right? Otherwise, we're just checking a box. And so we can tell them why, asking about substance use and pregnancy is important so that we can provide you and your baby the best and safest care. And giving some examples of reasons why. For example, some people may have withdrawal symptoms while they're in the hospital, and we can treat that, right? Assuring them of that. And we can even start treatment medications if a person wants to, and help arrange follow-up after they leave the hospital. So you're really opening up this whole new world for patients. And then telling them what to expect for infants. Certain substance exposures before birth might just mean we need to watch them more closely and make sure that we follow up to monitor development, and setting those expectations up front. I talked to a lot of moms after the fact with lived experience, right? And they say, like, I didn't know any of this. Nobody told me. Nobody told me that these were options. And so I don't think we can make assumptions that folks have this knowledge. I think we have to really put that out there and let them know that we are here to help. We also want to make sure that patients who deliver their babies here are safe to take care of themselves and their infants. And if someone does report substance use, just reassuring them, we have resources here. We want to work together to make a plan for the safety of the whole family. And so these are just some examples of scripting that you can use that's very reassuring, hopefully to the patient, and maybe invites them to be more forthcoming about their substance use. So again, you say this to Quinn, Quinn agrees, but expresses concern about CPS reporting. Anybody had this experience with a patient? And seeing some nods there. I think that this is probably, as a mom, I can say that the most terrifying experience I can imagine is having my children taken from me. Out of my cold, dead hands, you could do that, right? And so this is a very reasonable concern to express. And so I think reassuring them, hey, sometimes people are very worried about talking about substance use because they worry that every and all substance use has to be reported. And then giving them other options or expectations. This may not be the case, though, when people are engaged in treatment, have safe housing or other support people to help. And you can even start talking and using that as an opportunity to say, we actually have a term for this. It's called plans of safe care. Is that something you want to talk about today? Is that something you've talked to your provider about? Now, Quinn comes to you with no prenatal care, so that's not likely going to be something that they've already done, but introducing that concept there so that when Quinn hears that term, as they go through this hospitalization, that's not a new term. So when social work or case management comes in to talk to Quinn, they've already heard that term from you and know what to expect, right? We're all sending the same message. So after talking to you, Quinn admits to substance use and is open to beginning methadone. You begin a standard inpatient methadone dosing. I know we talked a little bit about methadone inductions last month in our coaching call. And so a standard methadone dose to start with for a patient who is brand new to treatment. And has been, maybe they've been on treatment before, but it's been months, right? We're probably going to start over again. And so a standard dose to start out with on day one is 30 milligrams. You can then give an additional 10 milligrams depending on withdrawal symptoms later that day. So you do that, right? Quinn's gotten a total of 40 milligrams of methadone. They are still experiencing withdrawal symptoms. Baby has not been born yet, has not transitioned at this point. So here's our next polling question, I believe. What additional medications can be given to help with symptoms? So you've given Quinn 40 milligrams of methadone. Their last use of fentanyl was about 9 hours prior. And so here are some other pharmacologic options that you could be considering for Quinn. And so do you think it's clonidine? So clonidine, I know, has historically been a blood pressure medication. It's a alpha-2 agonist. We have hydroxyzine, right? So hydroxyzine is antihistamine, but is really used mostly for anxiety. Acetaminophen, of course, for pain. And then ondansetron for nausea, or E, all of the above. Give y'all a couple of seconds to look at that. All right, Sydney, what did folks think? All right. So it looks like most thought that you could do all of the above. And I agree with that. And so I'll show you as we continue going.
You have a quick question in the chat as well. John says, why not more methadone?
Yep, great question. So methadone, I know probably those that are in active treatment that come in and you call their OTP and you find out their methadone dose is 130 milligrams a day, right? And so you give that dose. But that is someone who has been maintained on it. Now, how methadone has been studied when it comes to initiating it is pretty specific. And so these recommendations are going to follow those guidelines. Also, methadone has somewhat tricky pharmacokinetics in that in the beginning, it acts more as a shorter acting medication that you can certainly use. And for pain, for example, it gets split into 3 times daily dosing, but that eventually builds up in a patient, whereas the higher the dose that you go, it is actually exponentially more potent. It's not a dose to response relationship like most medications that is like a 1-to-1. If you're on your X and Y axis, kind of that looks like 1, it actually becomes a bell curve that goes up like this. So the higher the dose, it actually becomes exponentially more potent. And so we tend to be very careful when we're initiating methadone, because what can happen is you start to stack doses and get higher doses, but you're not getting a 1-to-1 response. And so all of a sudden someone is over sedated, maybe their breathing becomes suppressed, and you're having to reverse and start over again. And so I think with the illicit fentanyl hitting the market over the past 6 to 7 years, we're starting to see emerging literature that does support more aggressive initiation of methadone at higher doses, or allowing you to escalate more quickly in certain situations. I would say that those situations are ones where you should be consulting a formal addiction medicine consult service, just due to these tricky pharmacokinetics. If you are an OB or an OB hospitalist, and that is not necessarily what you do all the time, I would very much suggest that you stick with our standard induction dosing and utilize other medications to augment Quinn's withdrawal, which we're actually going to talk about next. These are some of the non-opioid medications that you can certainly use to augment her withdrawal. And I like it because each of these really tell what really symptom that it's targeting, right? And so you have a lot of options here to choose from. This is really built in all of our Moms Plus protocols to be able to select based on symptoms. And you can see you have several agents, both for things like nausea, for insomnia, of course, the abdominal cramping that can come, right? And diarrhea, as well as the clonidine is really for that restlessness, and also some of the kind of increased heart rate and blood pressure that we can see, and anxiety that folks can see. So these are all really, really great non-opioid options that you can utilize to help with some of the symptoms. But let's really get at the question that you just asked of like, if adjunct medications do not help, what else can be given? And I hope I just explained why you shouldn't necessarily give more methadone up front, but let's talk about maybe some other options that you could. So our next polling question really being here: A, morphine extended release; B, hydromorphone; C, oxycodone; D, none of the above. Why would I give Quinn more opioids? Or E, all of the above. I could give any opioid. And I'm just curious, before we dig into it, kind of where folks' baseline knowledge is on this. So give you a couple seconds to think about that and respond. All right, Cindy, you want to show us our responses here?
Yep. Go ahead.
Okay, I would love to hear, so who responded, and if you feel comfortable coming off mute, none of the above. And we'd just like to hear why, because I always love to hear folks' thought processes. Okay, who put all of the above and feels comfortable maybe saying why?
Also, feel free to put your answers in the chat if you feel comfortable doing that as well.
All righty. I am going to just talk through each of those. So I'm guessing that some folks put none of the above, maybe because we've already given methadone, so we've given an opioid. Why would we give more necessarily? I would prefer IV opioids to better control timing, but any of these may help. Jesse, great response. And of course, hydromorphone could certainly be used IV or oral. And then for those that thought all of the above, I would agree with that. I think what we have to understand about Quinn, especially coming from illicit use of fentanyl, which is incredibly potent, and knowing the risk of dose escalating the methadone too quickly, we really need to rely on some other shorter acting, more reliably pharmacokinetic opioid agents, right? So we know with that very potent fentanyl, Quinn's tolerance of opioids is probably incredibly high. So even with that methadone 40 milligrams, Quinn is likely still experiencing significant withdrawal symptoms. And so we're not going to get Quinn to be out of withdrawal responsibly using methadone without probably overshooting. And so let's utilize some of our more predictable agents here. And so these are really the three that have been studied specifically for pregnancy and are in everyone's formulary for the most part. I would say use whatever opioid you feel comfortable with. I love Jesse's suggestion there of IV opioids. Totally agree. I think sometimes folks maybe go towards the oral because they last longer. You can get a little bit more even sustained relief. I think if Quinn's in acute withdrawal and really miserable, absolutely give some doses of IV fentanyl, give some doses of IV Dilaudid. This is not make Quinn suffer through it. That is never the point here. And I will say, early in my career, that is the attitude I had. Okay. That is the attitude of they need to experience withdrawal so they never do this again. And that's completely, I feel terrible. And I'm trying to make amends for how I used to treat these patients early in my career. It is not going to do Quinn any good to have Quinn experience withdrawal. It will actually probably do Quinn harm. Quinn will be less likely to stay in the hospital, less likely to receive perinatal care for both Quinn and Quinn's baby, and less likely to ever come back to a healthcare setting again. And so we really need to make sure that we are keeping folks out of withdrawal that not only keeps them more comfortable, but it maintains tolerance. So if Quinn did leave and continue use, less likely to overdose that first or second time when they do use, right? And so I would say, don't be afraid of using full opioid agonists. The inpatient setting is like the only setting where we are legally allowed to use full opioid agonists to treat opioid dependence and opioid withdrawal. So take advantage of that. Any questions about that? Anyone that's like, still not a believer? Judgment-free zone. Safe place to ask questions. Cool. We will continue on then. So this is just showing us an example of one of our Moms Plus protocols. You can see here we have, say, opioid agonists may use in addition to methadone if that's insufficient to alleviate symptoms. And so you can see there we have both hydromorphone and oxycodone, some little bit bigger doses to feel very free to use. Here is an example on the right side in cases of really high tolerance, including fentanyl use, of what we might just anticipate needing up front. Right. And so that may be Quinn. Quinn says, I use heavy fentanyl. Let's say I smoke 30 tablets, 30 blues a day. That's a patient. We're going to be like, all right, getting methadone 40, and I'm just going to give some MS Cotton up front and hydromorphone around the clock. And then as you can see, you can slowly increase that methadone each day. But again, just being cautious about it due to those tricky pharmacokinetics. And you can see, right, that after day 3, as you start to get up on it, you're reducing that morphine extended release dose and maybe backing off on the immediate release. And so just compensating there. So lots of great options when you're in the hospital. So my hope there would be that Quinn has a good experience with that birthing hospital, is able to have a successful delivery, is able to get plugged into treatment at an OTP afterwards to continue methadone, has a plan of safe care in place, and is able to either keep baby or be reunited with baby at some point. At the very least, let's say Quinn's baby was still taken away, right? Quinn does not follow up at an OTP. You have maintained Quinn's tolerance while they are there in the hospital. That makes it much more safe for Quinn to return to use when Quinn leaves the hospital, much less likely to overdose, and also remembers that they were treated with dignity and evidence-based care. So hopefully we can all feel better about that interaction than Quinn coming in, us not making Quinn feel welcome, maybe they weren't forthcoming about their use and left AMA. All right, we're going to move on to patient case number 2. So this is Harley. Any questions on Quinn or anything anyone would have done differently or disagrees with? All right, if you think of it, throw it in the chat. I'm going to continue on. This is Harley. Harley presents to L&D in active labor at 38 weeks. She chronically uses heroin, does not desire treatment. Her cousin is planning to adopt her baby, and Harley is not ready or willing to change her lifestyle. She threatens to leave AMA and have the baby at home if she starts withdrawing. So this is talking about a little bit of staff scripting. So you have a positive substance use screen, right? Harley's super forthcoming. Her use was known throughout her pregnancy. She has a plan of safe care for her baby being adopted by her cousin. But this is a great opportunity for us to still really lean in. Again, Harley has expressed to you she's not interested in treatment, but let's still use this as an opportunity for a positive interaction, right? Since you and I have talked about your substance use, I would like to share this information with your doctor, midwife, and they can help you decide on any next steps for medications to help with your withdrawal symptoms or treatment if that's something you change your mind on. Well, you are under our care. And so really reassuring Harley, hey, yep, got it. We're going to keep you comfortable. That's evidence-based care. We're here to help, not harm. And let's make sure we communicate this with the right people. Harley is not accepting of treatment. She kind of already explained that to you. And so you respond, thank you for letting me know where you're at. We want to meet folks where they're at, right? Wherever they are in their journey. Are you having any symptoms or cravings now, right this moment that I can take care of and get someone in here to talk to you about and get some medications on board? We might be able to help you feel more comfortable while you're here in the hospital. So again, just really reassuring Harley that you're there to help. So our next polling question is, how do you proceed in managing Harley's opioid use disorder, right? It's like, you know about it. She's not interested in treatment. She said that. So what are your options here? And I think this is previously where many of us maybe would have felt really like we didn't have options to offer her. And we would feel really powerless, right? And that's what we're trying to change. We're really trying to empower staff to feel like they can still address Harley's needs. And so here, A, ignore it. Hope the baby comes quickly. She doesn't get in too bad a withdrawal and you send her back out. B, refer her to treatment anyway. She needs it, right? You know better. C, try to guilt her into changing her mind, right? Maybe starting to use some coercion. D, give her opioids. Or E, I'm not sure. I'm going to give folks a couple seconds to think about this because I think historically this has been a tricky question and hopefully we can start changing that.
We have about 50% of people who responded, so feel free to take a couple more seconds and respond.
All right, Cindy, you want to show us what folks think? All right, looks like one thought, I'm going to refer Harley to treatment anyway. No one was trying to guilt Harley, so no one's trying to ignore her. Thank you. Give her opioids, or I'm not sure. Yeah, those are all I think very reasonable answers. There's not always one right answer. But I definitely do agree with, and it seems like folks kind of got the message from last time, even someone who did chose treatment, right, with methadone, that we can still give opioids. We're in the one setting where that is at our use and at our disposal, and we should be utilizing it. So I completely agree with that assessment there. So luckily, you have a comfort order set to provide methadone as well as full opioid agonists to prevent withdrawal symptoms. So I know in Quinn, we used methadone starting at that 30 plus 10 milligram dose to initiate treatment. Methadone can also be used at low doses to prevent withdrawal. So you're not trying to dose escalate up necessarily, just as a baseline, and to maintain tolerance. Okay, so really, really useful tool, even if you don't plan on continuing it afterward. Harley has expressed, I'm not going to an OTP every day. It can still be an option as one of those full opioid agonists, as long as we're not trying to dose escalate up, right? We're just using a standard dose there. So you explain to Harley that you will give her opioids while she's in the hospital. This will also help her, like I said, maintain tolerance and decrease the risk of accidental overdose after discharge. And you talk to her about that. Like, hey, the last thing I want you to do is be uncomfortable, lose your tolerance, be at higher risk of overdose. Let's keep you and baby safe. Harley's agreeable to this plan and says, you know what, I will stay. Thanks for treating me like a human. All right, Laurel Irwin also offer her naloxone. Love it. You already know the next polling question. It's blasted up there. What else do you want to do for Harley? So we got a few options here. Provide take-home naloxone, spoiler alert, love it. Offer referral for peer support and harm reduction services. C, offer to provide information on treatment programs in case she does become willing in the future. D, discharge her with a prescription for Dilaudid. Or E, A, B, and C. I'm going to give folks a few seconds to think through that one and see which option or options you like. There might be more than one that's correct here. I think we can all agree on A being correct, but.
About half have responded so far.
All righty, let's see what folks thought. Oh, I love it. Rarely do we get unanimous votes. So it sounds like everyone is super on board with all the things we talk about: providing take-home naloxone, offering referral for peer support and harm reduction services. Talk to Harley. How are you consuming your fentanyl? Are you smoking it? Are you injecting it? Are you snorting it? Trying to get more curious about that, because that can really determine what services we offer. I don't want to refer Harley to a syringe exchange program, right, with Lisa down at Harm Reduction Action Center, if that's not what she needs. But if it is, I want to make sure she has the clean tools that she needs to inject safely, and I can talk to her about those practices. So definitely always peer support, even for those in active use. A peer can be so essential. I mean, think of the trauma Harley is going through. She just carried this baby in her for 10 months. She is now delivered. I know that she had always planned on that going to her cousin, but it's really traumatic to then lose that child, right? You want to make sure she has some follow-up and support regardless of continued use. And then offer to provide information on treatment. Absolutely. We're not going to try to force folks into treatment unless there's a court mandated order. That's a whole other situation, the legal order. But otherwise, we find it to be most successful when it's a shared decision, right? And the patient is willing. Rarely is forced treatment successful. The literature shows us that. But we can use some of these tips and tricks and motivational interviewing to hopefully invite their participation. Right. So one thing I hear a lot about is, how do I start this conversation about take-home naloxone? Because sometimes that can be a little bit uncomfortable for bedside staff to talk about. And so we do provide some scripting suggestions to use the first few times. And one thing that you can really say is, hey, we actually just normalize it. We offer this to everyone. You've told me some things that definitely make me think that you could benefit from it. Most folks in active use at this point in 2023 are familiar with naloxone. So you can always ask Harley, do you already have some? Shouldn't stop you from giving her additional doses, but certainly talking about overdose is one of the leading causes of maternal mortality. Let's say Harley wasn't in active use, right? And you were just trying to convince another mom that you thought should really have it in their household. Having naloxone more widely available in our community is an important step to prevent these accidental deaths. And just talking about it's important for people with and without substance use to have it available in case of emergency. Can I tell you more about it? And maybe send you home with the kit and then say, hey, I carry it too. I think it's a really responsible thing to do. So if you don't carry it, you should. And Dr. Stater or Dr. Cleese happy to write you a script to go get filled, or we're happy to send you a dose. Please let us know. So let's talk a little bit more about harm reduction. And hopefully we can all be harm reduction believers after this. But I really think of harm reduction. Don is on. Hey, Don. I will prescribe anyone naloxone who wants it. Yes, or we'll just send it straight to you. We have lots of awesome keychain doses we can send. But harm reduction is a set of practical strategies aimed at reducing negative consequences associated with chronic conditions. And one of those chronic conditions is substance use disorder, right? Or substance use. Harm reduction is not condoning use. And so that's a common myth, right? If I give folks clean syringes and clean needles, it is encouraging their use. They will use more. If I give folks naloxone, they're more likely to use more and use less safely. And that is not at all true. It is providing access to all of the things that we've talked about today, not only naloxone, but overdose education, safe storage and disposal, asking about other infectious disease screenings for things like HIV and hepatitis. And we actually find that harm reduction decreases unsafe drug use, right? And studies really support that. So please don't let that be a myth. Partnering with patients collaboratively to develop harm reduction strategies is really a key driver in helping develop care choices that are relevant to your patient, that they'll actually participate in and use, right? And inviting them to make that plan with you. Harley's already expressed to you, right, that she's not interested in treatment, but that doesn't mean the conversation stops there like it previously would have. You're talking about the things you can give her during her hospitalization to keep her comfortable and maintain tolerance. You're talking about naloxone, keeping her safe in the future. You're talking about, hey, you may go visit your baby at some point with your cousin. Let's talk about safe storage of your fentanyl, making sure it's locked up and your baby can't get into it. So all of those things that are going to keep Harley and her family safe. I also just always like to point out that harm reduction is really good medicine. And once you lean into it, I think it's very empowering. I think most of us as clinicians do not like taking care of people with conditions that we feel ill-equipped to address. We don't have the answers. So previously, we didn't like screening patients, right? Because what were we going to do with that positive screen? What would I have to offer Quinn or Harley? And now we have options, right? And it's not all the same. It doesn't all look the same. So some patients with a use disorder will not be ready for sobriety or formal treatment before, during, or after a pregnancy. It doesn't matter how many services or resources you provide. But I will tell you, harm reduction is the treatment for people in active substance use. It's a very tangible thing. Handing someone naloxone is a very tangible thing you can still do to protect that patient, their family. And it's also creating that connection and inviting them to come back maybe when they are ready for things like formal treatment. And they'll still be alive to access it, right? And it keeps that door open. So I see some snaps there. I like it, Ms. Irwin. So principles of harm reduction applied to perinatal and postnatal populations. So again, it just personalizes our risk reduction options. I think when we start to apply it universally to all patients, not just our Quinns and our Harleys, it can start to impact our own internal bias. Right. And so it can really help us come to all of our clinical encounters with greater compassion and a more trauma-informed approach to their care. For those with active opioid misuse, staying alive is the precursor to accessing some of those other things we would like them to attain. And so universal access to these harm reduction strategies is really so key to reducing mortality and giving women and patients a chance to further engage in health, in our health improvement. And I also just like to remind folks that patients not aspiring to the level we wish for them is not an indication of abstinence, right? And so I think about this for other disease states. How many patients that suffer from diabetes who aren't engaged maybe in the diet that I would like them to, or the exercise level I would like them to, or their insulin regimen as strict as I would like them to. Same for patients with maybe heart failure. They're not following the low sodium diet that I want them to. But I don't hold that as a moral feeling against them. I don't refuse to offer them care, right? I really see that they're doing the best that they can. And just because they don't want to attain this really high level of health and care that I want for them is not an indication of abstinence. It's just an opportunity to collaborate with them and develop strategies that they will engage in. And so I just like to remind us of that and really normalize this. So here's just a couple of points about take-home naloxone that I like to bring up. Bringing up naloxone is not accusing people or assuming they'll experience an overdose event, but it is acknowledging that in 2023, fentanyl has changed the game. My kids can be playing at the park and find a fentanyl tab and think it's candy, right? So I just think that we need to start universally applying some of these harm reduction strategies and start living in reality, right? And just acknowledging the vast majority of overdoses are accidental. We're starting to call them poisonings, right? It's no intention, not what that patient or person thought they were getting into. And then comparing it to another thing. My husband is deathly allergic to bees. He carries 2 EpiPens. He lives in a world with bees. He has to carry them. We live in a world with substances. Let's start carrying the antidote to that, right? Especially for those at highest risk. So I would just like to plug here that if you're not already involved with Moms Plus, you can still have access to all of the great order sets that our experts have worked on, okay? And it's about more than just opioids. We also have them for things like alcohol withdrawal, stimulant withdrawal. We know that many folks are certainly have substance use disorders involving methamphetamine and cocaine, and that is often equally as difficult to manage during especially birthing admissions and keeping folks comfortable. And those are all resources that we're happy to share. We're currently working on getting all of those up on a website that we'll make sure to send out to all participants in CPCQC's kind of SUD related initiatives, including AIM-SUD, just as a precursor to what you could be adopting at your hospitals. And we're also happy to help and really provide that technical assistance of how to implement that if that's something you're interested in. So I am going to stop sharing and open it back up to questions, comments. Yeah. Hope everyone got something out of that. I see Dr. Stater is on now. Don, I don't know if you have anything you want to add. I know you were coming from another call, but we were able to chat about Quinn and Harley today and kind of talk about some options that we feel like we historically didn't have for these patients that we can now feel really empowered to use and be doing.
Yeah, I think so much of what you say kind of resonates with me and kind of as an addiction doc. And I'd say that this becomes so easy to talk about after a while that it really becomes second nature. And I think about how patients respond to this type of more compassionate, open care, understanding care really has been a game changer for my relationship with this patient population from the first half of my career where I got most of this wrong. And I think that the other thing I hear about a lot is, well, is that type of stuff endorsing drug use or is it permissive of drug use? And the answer is no, that is not. In fact, having people feel better self-worth, feel worthy is actually one of the biggest drivers of recovery, is people start feeling like they're worthy of treatment and worthy of doing things differently. So yeah, that's all I got to say about that.
Thank you both so much. That was a great presentation, Rachel. Thank you so much. Yeah, this is really an open Q&A portion. People, please feel free to ask any questions you have about Moms Plus, Coimbs-Sud, MOUD and delivery and labor. It's really kind of open for you all right now.
Another key, I guess, point here, and I'll just say that I've learned about asking questions to sensitive populations is sometimes to ask them directly, well, do you use substances, is sometimes difficult. And because of the legal ramifications of potential substance use in pregnant persons, people will be very guarded to say, oh yeah, I, occasionally use methamphetamine or fentanyl, etc. So one of the ways that I generalize this is, does anyone that you know, friends or family, use substances that might put them at risk or you at risk? And you get a lot more positive answers when the screening is much more broad. The other way that you get positive answers, which is a nuanced way, is instead of saying, do you do this? Ask, when is the last time you did this? Because then it almost accepts, you're kind of leaning into, it's okay if you say a positive result. So when is the last time you may have used a fentanyl product? And, if people are like, oh, well, like never, then okay, that's a negative result. But I think also that type of questioning and how we actually ask these questions can be really, really important in showing that we're sympathetic, that we understand the disease of addiction. And yeah, those are other just tricks and tips.
I have a quick question. My name's Laurel. I'm a midwife and a family nurse practitioner. And first of all, Rachel, thank you so very much. Like, you just exude empathy. And I just, as serving on the MMRC, just these countless senseless deaths, like just meeting people where they are without judgment and inviting them to share their story and building that relationship, because that's what's going to save lives. And you just give so many good examples of how to do that. But I haven't been doing a ton of family practice right now, not much MAT. And I just wanted to know, because I'm a little bit rusty, if I do have a patient come that I need to like double check doses, if they're a little unsure, depending on their use and that sort of a thing. There was a MAT hotline that's an 855 number. What's another good resource? Do you like a phone number that I can pick up? Hey, this person just walked in to the ER, she's under my care, like whatever, or she just all of a sudden I've discovered this use mid-pregnancy, like how do I, what dosages, whether that's going to be a MAT medication, methadone versus opioid.
Yeah, so poison control is a great place to start, and has a specific hotline, especially for buprenorphine type inductions and specifically for pregnancy. Can also walk you through withdrawal management. So if you're just like, all right, I need one number to call, that's a really, really helpful one. They can get back to you pretty quickly. I think it's for those types of requests, a non like super acute, like still acute, but it's a warm line where they can get you the right, and very, very astute at walking providers through that maybe it's been a few months since you did it. And Don has his phone number in there as well. He doesn't mind being texted. We didn't go through any buprenorphine cases today because we did those last time, but
that's what I was going for. Thank you, Dr. Don.
Yeah, and if you want to, I dropped my email in there. If you want to email me, I can also send you some of those protocols we talked about that I think do a really good job of walking you through how to start either methadone or buprenorphine for these patients. And from a buprenorphine standpoint, both standard induction as well as a micro or low dose induction, especially for example, Quinn had really heavy, both I think patients had heavy fentanyl use. That has really changed how we do our buprenorphine inductions, right? To having to be more of a low dose induction. You can't just like slam them. I mean, you can, but you're going to be dosing over and over and over again, and they're going to be uncomfortable. But happy to pass those along as tools for you as well.
Yeah, thank you. And I feel like bupe I'm a little more comfortable with, but like adding the opioid like that piece, like I think I would want to do a quick consult if it came down to that sort of thing.
And that's fair, right? If you're not an addiction doc, if that's not something you do every day, like that's kind of where I was getting at with the methadone piece. And illicit fentanyl use has really brought methadone back into favor in a lot of patients. And especially if you're in an area where you have decent access to an OTP, I mean, rest assured that if you have access to one, they are required to get a pregnant patient in within 24 hours. Like they are prioritized across the board. If you ever have an issue with that, please let us know. We'll do some work on the back end to make sure that that's happening. We've done that many times before, but overall I've had really great experiences with DHG and BRG and all of those. But don't be afraid to utilize that. That's very much at your disposal as well to start methadone in patients and getting good follow-up as well.
And I should say methadone in the hospital setting. You know, yeah. So that's the only caveat. And in many ways, in the hospital setting, it's actually better to start methadone because then you actually take away a lot of the bureaucracy around intakes. So it's actually a loophole in methadone where if you start and then you escalate people, let's say 40 milligrams, which is oftentimes needed. We're seeing higher doses of methadone needed for fentanyl use disorder. Then you can actually really jumpstart their treatment and be more aggressive with their treatment. You know, different hospitals that have addiction medicine docs, like I know, for example, Amber, your addiction team at Denver Health is really amazing about rapid escalation of methadone so that you're not waiting like months for like, you know, people to get to a dose that actually works for them. So, you know, there's definitely a lot of nuance in evolving medicine here, but
yeah, I think
it's a huge service.
Yeah, kind of before you got on, Don, we talked about our patient and why we wouldn't just give more methadone. And we talked about the nuances of methadone pharmacokinetics and why if you're a family med doc or OB hospitalist, like probably follow 90% of the time our standard induction. If you want to do a more rapid one, call an expert to just weigh in. You know, I think that's a super fair thing, especially your first few times. But that said, I think we'll start to see more emerging literature, making us more comfortable doing more rapid inductions. Yeah. Michelle, I see your hand up.
Yeah, I know that working with the Moms Plus implementation project, we'll get more resources for this. But in terms of, I don't think we have any providers who would want to try methadone induction at this point, but we have always been told that 40 milligrams is the max we can use in the hospital if they aren't already engaged in treatment. So how would we work with our pharmacy to do that if we wanted to?
Yeah, Michelle, after our lunch and learn, we met with 2 of your OB providers about that, and that was their understanding as well. And so we'll be getting y'all your kind of like finalized gap analysis with that recommendation of hey, just some further education and collaboration with your pharmacy team on what is actually legal and not legal, but it's certainly very within your legal rights to go higher than that, especially in the hospital setting, as long as there is decent intent that those folks will follow up with an OTP and help you get plugged into an OTP so you can make that a reality.
Perfect, thank you.
Yeah, definitely a very common myth though. Yep.
Well, thank you all again. I know we're coming close to time, but if people have any last minute questions, thoughts, discussion points, please feel free to come off mute or throw them in the chat. Otherwise, I want to thank you all so much for coming to this lunch and learn. Please feel free to reach out to Rachel or Dawn. I'm going to pop my email in the chat as well if you have any other CPCQC questions. Thank you all so much.
Thank you.
Thank you, friends.
Thank you.